Okay, this is a multi-center retrospective study to look at the high risk factor associated with COVID-19 progression. So core score actually stands for underlying comorbidity, older age, higher LDH, and lower lymphocyte. They were identified as independent high risk factor associated with COVID progression. It is a novel scoring model to predict progression with optimal sensitivity and specificity. So my presentation today will cover background, methods, result, discussion, and critical appraisal.
Okay.
The outbreak of COVID-19 due to SARS-CoV-2 infection has influenced all provinces of China and spread to over 180 countries worldwide since January 2020. The number of new and severe cases have been increasing rapidly daily due to the easy transmissibility of the virus by patients with only mild illness or asymptomatic carrier. Patients who require ICU care were significantly older and more likely to have underlying comorbidities. Previous studies identifying risk factors associated with severe COVID cases were single-center and univariate analysis-based study without considering the influence of confounding factors because of small sample size. Therefore, clarifying the independent high-risk factors with multivariate analysis and establishing an accurate prediction of progression of COVID-19 become desirable. So the objective is to clarify the high-risk factor with multivariate analysis and to establish a prediction of disease progression so as to help clinicians to better choose the therapeutic strategy. So in the methods, the study population this study is approved by both Ethics Committee of Fuyang Second People Hospital Anhui and Fifth Medical Center of Chinese PLA General Hospital in Beijing. So it's in two different provinces. Written informed consent was waived in view of the designated hospital for new emerging infectious disease. Both hospitals were assigned as COVID-19 treatment center on January 20, 2020. Patients presenting with severe COVID were excluded. This is a retrospective, non-interventional study. All patients with confirmed COVID-19 admitted to either of the two centers since January 20, 2020 were enrolled. COVID-19 was diagnosed based on WHO interim guidance and guidance for coronavirus disease 2019. The presence of SARS-CoV-2 in respiratory specimen was confirmed using real-time PCR assay by local district level and municipal CDC. Their exclusion criteria are primary infection caused by other pathogens such as bacteria, fungi, other respiratory viruses, mycoplasma, or chlamydia. Severe COVID-19 was excluded. So how they define severe COVID-19 was at least one of the following: respiratory rate more than 30 breaths per minute, resting oxygen saturation less than 92%, PaO2, FiO2 less than 300, or requirement of mechanical ventilation. Progression to severe COVID-19 was development of one or more of the above or worsening of lung CT findings during the observation period. All the suspected patients received treatment in an isolated observation ward at district hospital. After the result of COVID-19 were positive by both district level and municipal CDC, the patient would be transferred to municipal designated hospital according to proximity principle by negative pressure isolation ambulance. So what are the data they have collected are presenting history, comorbidities, lab parameters including complete blood count, coagulation profile, liver function test, renal profile, LDH, and procalcitonin on admission. Oxygen saturation by both pulse oxygen saturation on room air at rest and also confirmed by blood gas. Respiratory specimen, which is nasopharyngeal swab or sputum for influenza, avian influenza, RSV, adenovirus, and parainfluenza virus. CUP65 severity score, chest X-ray or CT scan. Comorbidity was defined as having at least one of the following: hypertension, diabetes, cardiovascular disease, liver disease, asthma, chronic lung disease, HIV infection, malignancy for at least 6 months. So the clinical outcome that measure are progression of illness, day to progression, mortality, discharge, and length of hospital stay were monitored up to March 18, 2020. The data in source document were confirmed independently by at least 2 researchers. So they analyze the data using continuous variable of normal distribution was represented by mean and plus minus standard deviation compared using the unpaired two-tier students t-test. Continuous variable of skill distribution were represented by median compared with Mann-Whitney test. For categorical variable was represented by numbers in percentage compared by the chi-square test. P-value less than 0.05 was considered significant for all the statistical tests. The statistical analysis were performed using R software. The significance of each variable were assessed by univariate and multivariate cost proportional hazard model for investigating the independent high-risk factor for progression of illness with its hazard ratio at 95% confidence interval. All the variables at a statistically significant level of p-value less than 0.05 were candidates for formulation of a nomogram. The predictive performance of the nomogram was measured by concordance index and calibrated with 1,000 bootstrap sample to decrease the overfit bias. A novel scoring model was established. Their relevant points were determined by multivariate cost regression to reflect their weights of impact on the progression of illness. High risk factor candidates, which are identified, D-dimer, LDH, were categorized based on their normal range. Lymphopenia was defined by lymphocyte count of less than 1. Older people was defined as age of more than 60 years based on WHO criteria. The performance of the scoring model was assessed using receiver operating characteristic curve. The area under ROC and optimal cutoff value were determined and assessed by sensitivity, specificity, predictive values, and likelihood ratios. So these are the results. First of all, they identify all the suspect patients received treatment in an isolation observation ward at district hospital. Once the patients are confirmed COVID-19 positive by both district level and municipal CDC, the patients will be transferred to the municipal designated hospital by negative pressure isolation ambulance, which is from January 20, 2020 to February 22, 2020. So out of this, they have identified 208 patients, 155 in Fuyang Second People's Hospital in Anhui Province, and another 53 in the 5th Medical Center of PLA General Hospital in Beijing. Overall patients that managed to get are 208. So univariate cost regression, multivariate cost regression, and nomogram analysis were done with bootstrap calibration. Finally, they established a nodal score model. So this is the test cost proportional hazard model. So let us look at the result. Table 1 shows clinical characteristic of enrolled patient on admission. Average age was 44 years old, plus minus 16.3. 117 out of 208 patients were male, which is 56.2%. 31 were older than 60 years old, which is 14.9%. 45 had at least one comorbidity, which is 21.6%. Average hospitalization time was 17.5 days, plus minus 8.2 days. So clinical characteristics are from here to here. Of stable and progressive group, they divide into stable group and progressive group. They have 168 in stable group and 40 in progressive group. Age, comorbidity, lymphocyte count, D-dimer, and LDH were significantly different on univariate analysis and log rank test by Kaplan-Meier analysis. However, they found that CURB 65 score is not significant. Further multivariate cause analysis showed that comorbidity, age more than 60 years old, LDH more than 500 were independent, LDH 250 to 500 and LDH of more than 500 were independent high risk factor associated with progression of illness as well as lymphocyte count of less than 1. A predictive nomogram was formulated based on above independent high-risk factor associated with progression and validated using the bootstrap method internally. The nomogram demonstrated good accuracy in estimating the risk progression of illness with C-index of 0.86. Calibration plot graphically shows good agreement between estimated and actual progression with a slope of 0.96 in 5 days prediction and 0.97 in 10-day prediction after 1,000 bootstrap sampling. Therefore, the formulate a score, a normal scoring module was established according to the result of the nomogram. Lowest score is 4 and highest score is 13. So price were given for with or without comorbidity, age more than 60, less than 60, lymphocyte count of more than 1 or less than 1, and LDH they divide into less than 250, 250 to 500, and more than 500. Lowest score is 1 of each, which you can get a score for. Highest is price additional of the highest price of each group, give a score of 13. ROC analysis was used to assess the performance of the core model. The area under ROC was 0.91. Using a cutoff point value of 6 points, the positive predictive value is of 95% confidence interval were 50.7% and negative predictive value were 98.5%. Using a cutoff point of 9 points, the positive predictive value, 95% confidence interval, were 78.3%, and the negative predictive value were 11.9%. So this is a summary of the core score. They assessed 208 COVID positive patients in Anhui and Beijing, China. Out of these 208 patients, 40 patients, which is equal to 19.2%, progressed to severe COVID-19 as defined by RR more than 30, PaO2 less than 93, or PaO2 PF ratio less than 300, worsening CT findings or on a ventilator. So 4 admission predictors were assessed, comorbidities, age, lymphocyte, and LDH. So each given a score of 1 to 4. Comorbidity were classified as hypertension, asthma, diabetes, liver disease, cardiovascular disease, chronic liver disease, HIV, and cancer. So score prediction. If the score of more than 6, 50.7% develop severe COVID, less than 6, only 1.5% develop severe COVID. So the core score can help predict who likely won't decompensate but not who will, means negative predictive value is higher. So in the discussion, the rapidly increasing number of new COVID-19 cases daily worldwide has put a heavy burden on the medical resources in countries with large outbreak. Identifying risk factor at presentation that predict the likelihood of disease progression will help the physicians to decide which group of patients can be managed safely in district hospitals and differentiate from those who will need early transfer to tertiary centers. Limitation of the studies identified are the sample size is small. It involves only patients in 2 centers outside Hubei and may not applicable for the patients in Wuhan and Hubei or may not applicable to the patients in the whole country. A prospective study is needed to confirm the reliability of core model. Adding other specific markers might improve the sensitivity and specificity. So the population of the study is clearly defined. All patients with confirmed COVID-19 admitted to either of the 2 centers since January 20, 2020. I'm sorry, this is wrong. The duration of enrollment was stated in the graph, which is from January 2020 to February. It is actually shown in the previous this one, January 2020 to February 22, 2020, which is slightly more than a month. Uh, Clearly defined risk factors are measured, clearly defined outcomes are measured. So using the core score model, clinician can improve the therapeutic effects and reduce mortality of COVID-19 with more accurate and reasonable resolution on medical resources. So other points in the appraisal is the study did not look at all the clinical outcomes it was stated earlier on, as mortality and days of hospitalization were analyzed, but days to progression to severe disease were not mentioned. Other potential high-risk factors associated with poor prognosis were not assessed, such as serum ferritin, cardiac troponin, CRP was not mentioned, IL-6 versus chest X-ray and CT manifestation. Okay, that's all of my presentation. Thank you.